and what to do there. We have a speaker, Ankit Vinayak.
Good afternoon. Thank you, sir, for the kind introduction. And I think this is a different kind of complication that all of us are going to face and all are already facing, where our patients are demanding spectacle independence. Our cataract surgery patients are getting younger and younger, and they want spectacle independence. They want independent life. And so balancing lifestyle, workup, and IOL choices for optimal outcome is my talk. So the first conversation is you need to set the expectation right. You need to tell your patient that no IOL can make your eyes a 25-year-old eye again. That is very, very important. All our present options cannot give us an eye which was at 25-year-old. So every implant is a compromise. We need to choose what compromise suits us. So we need to choose benefits versus cost. This is my rule. I tell my patients that, this is a 90-10 rule, that you need to decide what you're going to utilize your eyesight for 90% of the time. Whether you want to do nighttime driving, whether you enjoy highway driving or sports, or whether you are an indoor bug and like reading, being on system. So it's very, very important for them to decide what their 90% is. That will help them make this choice more effectively. So discuss this with their patient. Next is understanding their lifestyle. What activities define their daily routine? Near, intermediate, and distance vision needs. Outdoor versus indoor. Professional versus leisure demands. Patients' expectations are set here. It's very important to know that majority of our patients in cataract age group these days, 40% of their time is utilized for near activities. So we should not underestimate the need for near vision. Majority of times, either they're on their mobile phones or YouTube or Instagram reels, and they are confined indoors. So near vision matters to them a lot. Previously, a lot of emphasis was laid on intermediate vision, but in practice, what we see is that near vision matters to our patient. So we need to focus on this aspect. So considering all of this, these are my two patient archetypes. I divide my patients into these two categories: highly active, adventure loving. My ears are raised as soon as a patient tells me, Dr. Saab, I am an daredevil and don't mind taking my car out for a spin to Murthal for a paratha. And, I would be very cautious in selecting what lens I'll be putting in this. In such patients, I prefer an advanced monofocal lens and high visual demand across all ranges. These patients, I opt for a trifocal lens. I'm not a very firm advocate of EDOF lenses because I feel that the compromise is far too much than the benefits that they offer. So these are the two types in which I divide my patients. So what I was speaking of, so these are the typical defocus curves of three lenses. In the orange is a standard monofocal lens. In the dark navy blue is EDOF advanced monofocal lens, and in the yellow is a very commonly used EDOF lens. I would not want to name that lens. So at 2 diopter defocus, the amount of very minuscule gain that we get is at a very huge compromise of contrast and distance vision and focus. So for this is the cost that we pay for EDOF. I feel that there is still a lot of work that needs to be done with the EDOF lenses. So at present, I stick with trifocal and advanced monofocal lenses in my practice. Uh, Good workup is paramount in giving your patients spectacle independence. So all my patients, I subject them to optical biometry. I use IL Master 700. I also use online calculators, Barrett's, LADA Superformula, to refine the power of the IOL. Ocular surface analysis is very, very important because it can lead to refractive surprises. It can lead to improper biometry reports. We need to correct tear film instabilities, meibomian gland diseases, dry eye, etc. Pentacam, I run all my patients through a pentacam. This gives me the higher order aberrations for cornea and the keratometric refinements in terms of posterior corneal astigmatism. OCT macula to rule out any subtle macular pathology is very, very important in such patients. We don't want to land up with a macular pathology post-operative. Toric thresholds should be very low when you're planning for spectacle independence, and especially for trifocal kind of lenses. So against the rule astigmatism, my threshold is at 0.5 diopters of corneal astigmatism. And with the rule is one diopter because the posterior corneal astigmatism is against the rule, so that will compensate for some amount of astigmatism. And with age, the PCA tends to keep on increasing. So that again compensates for with the rule astigmatism. So that's the reason for these thresholds. Now this chart basically summarizes all of it, patient's lifestyle, lens options, customizing surgical plans, preoperative counseling, biometric measurements, and eye examination. Now after this, we have a lot of options in today's world, a lot of choices when it comes to trifocal lenses for making our patients spectacle independent. I have implanted almost everything out there under the sun and thousands of them. So with the experience that I have, this is the lens that I find most impressive. This is the Vinayak geometric family. This is a very novel concept because it comes with a pairing. There are two lenses in this category, the geometric and the geometric plus. So basically light available to every IOL is the same. It is the way that this light energy is utilized in giving our patient a good range of vision. That is what these lenses help with. So these are the two lenses here, the geometric and the geometric plus. They are available in toric version also. The geometric gives an excellent vision for far, a good near, whereas a geometric plus will give you an excellent near. So although the power is the same, the near add is 3.5 for near and 1.75 for intermediate. It is the light distribution, the way the energy is utilized and distributed for the distances. So that's how you're able to give a good spectrum of vision. So this is the patented design for geometric, where the diffractive zones are only in the central 3.2 mm. So you can see it's basically a combination of trifocal as well as a monofocal lens. So as soon as the patient goes out in a low light condition, pupil dilates. This will also lead to lesser photic phenomena and give patient a very good distance vision. So that is a very, very impressive design, which is responsible for the kind of results that it gives, which we will discuss here. So as you see here, in a geometric, in a low light condition with a 4.5 mm pupil, the distance vision is very, very high. And in a well-lit condition, the geometric plus amounts for an excellent near vision, which is indicated in dark red. Yes, I'm summarizing. So I'm just concluding. So this is here we see, the efficiency of this lens in terms of distributing the available light and making up for a very fine vision. So geometric at 3 mm pupil, 50%, 51% of, and as the pupil dilates in low light condition, when you're going out for a night drive, you see almost 70% of available light is available for far distance. Whereas in small pupil with a geometric plus, almost 36% of light is available for reading. So such is the wide distribution with this pairing kind of an approach. This is the defocus curve of the two lenses individually and binocularly as well. So I will just summarize. It has excellent rotational stability. This is a spec sheet available from 10 to 30 diopters and T2 to T6 toric versions. So this is basically the pairing approach that I use in my patient. So the right balance is the combination of these two lenses, geometric and geometric plus in the two eyes. I generally prefer implanting a geometric in a dominant eye because that is the eye that we use for distance. If we go on a Diwali Mela for shooting or anything, so that's why I prefer implanting geometric in a dominant. If you have operated one eye and you have landed with a suboptimal near vision, you could opt for a geometric plus in the second eye. So likewise, you can mix and match and ensure satisfaction in your post-operated patients. I would like to sum up with that. Thank you, sir.